Yeah.
We are live.
Gotcha.
We're live, Senate Appropriations. We're going to go through a
Check
couple of
everything else
bills
out.
that have been referred to our committee because of the appropriations. First is we will take up is S 206, which is the child care licensing bill, or at least that's what I call it. I thought we would just have joint fiscal. The legendary Ted Burnett can run us through the fiscal impacts of this bill, which I think will also tell us basically what the bill is. And then Senator Lyons is here. She can tell us anything else about it. And then I will entertain.
Okay. Okay. That's fine. We just voted on it, you know.
We could do that. Just vote. Okay.
I gotta go.
Ted Burnett, Joint Fiscal Office. Would you like me to share my screen, or do folks have what they need?
It's sometimes helpful to share this.
There is one table that breaks down expected revenue by the different licensure types. So I am clicking on the Zoom link now.
While we're waiting for that, Senator Lyons,
Yeah,
do you want to say any opening comments about S 206?
yeah. I think it's a important bill for the profession of early childhood educators. Will provide them with the credentials and the licensure that they need to work at different levels within their child care centers, and establishes a system for that licensure, and provides for time within which the system can go into effect. I think the Office of Professional Regulation has done a really good job in delineating different levels of licensure and the work that folks would do once they enter the profession. It's good.
Okay, sir.
Sure. So I will, Ted Burnett, Joint Fiscal Office, again, for the record. First talk about expected licensure revenue when the licensure provisions go into effect in fiscal year 29. So there are initial applications and license renewal fees. So in fiscal year 29, folks in the profession will be paying a range of initial application fees. So for early childhood educator 1, for example, they'd be paying $125, all the way up to $225 for ECE educator or ECE 3. And so based on information that worked together with OPR to develop these estimates, the amount of revenue that would be generated in that first fiscal year from the initial application fees is $800,000. And then 2 years later, folks in the profession would renew their licenses. And so those license fees are higher at renewal than they are at application. And so there would be approximately $1.2 million biannually thereafter. In between, so in even fiscal years, there would be some folks entering the profession, and so they would pay their initial or renewal fees in like an off schedule, and we're anticipating that's $100,000 in the even years. And these license fee revenues would be deposited in the OPR Professional Regulatory Fee Fund. So, moving on to the appropriations. In fiscal year 27, OPR, the bill would create 2 positions at OPR. One is a full-time executive officer for the board of early childhood educators, and then there's one full-time staff attorney. The bill would appropriate $262,000 from the general fund in fiscal year 27 to fund those 2 positions. Since fee revenue would not be available until fiscal year 29, by creating those positions in fiscal year 27, there's not a funding source yet in fiscal year 28, so just want to flag that in fiscal year 28 and a year from now, you would likely see requests for funding of those 2 positions.
So but the fees would start in 28?
In 29. So there's a bit of a ramp up, getting the whole structure in place before fee revenues are available. I will also note that the OPR Sunrise report for regulating the ECE notes that an additional 3 positions beyond those 2 that are created in the bill would be required to implement licensure at full scale. They may wish to bring in those positions online in fiscal year 28, or they may wait until fee revenue is available. But in total, so to the question of why we're looking to generate $800,000 of revenue, $1.2 million, it's to support a larger set of positions than the 2 that are created in the bill.
So on the fiscal impact part, it said 800,029, approximately 1.2 million, 2 million biannually, which I think of as every 2 years.
Every 2 years, yeah. That's
So
correct.
why is it more than the first year than it would be annually after that?
In the first
First year's 800,000,
Yep.
and then it's only going to be 600,000 every year after that. I'm doing my math right.
So yes, the 800,000 in the first initial year is because folks are paying their initial application fees. Which
And
are
the
lower.
renewal is a different fee that are there,
Yes,
right?
Yep.
Or seems like it's more, the renewal fee.
the renewal fees are more.
But don't you think you would raise more in the years after it's up and going than you would in the first year?
Yes, so the $1.2 million would be in fiscal year 31 and then fiscal year 33 with those
But
higher.
then that's
renewal
only
fees.
600,000 a year.
Yes, so they're,
Why is it 800,000 one year, 600,000 years after that? That's my question.
so the every 2 years, it's basically the way to think about it. So there's $800,000 in fiscal year 29.
Yeah.
There would be some folks who would pay their initial renewal fees in fiscal year 2030. That would be a relatively small amount,
Because it's a
certainly less
2-year
than
license.
100,000. Yep, and then in fiscal year 31, there'd be $1.2 million, and then $100,000 in fiscal year 32. So you'd have these 1 year with a lot of revenue. The off years.
I
would
didn't
have
get that it was
considerably
a
less.
2-year license.
Yep, and so then in the collective funding of $1.3 million would be enough to pay in this imagined structure for the positions in the bill. Or sorry, not the positions in the bill, but the positions when the program is fully up and running.
And do you know how this compares to the other licenses, like the appropriation? Or I guess it would be positions to the number of licensees.
That I unfortunately don't know. I will say that these licensing fees, as far as I've seen, compared to, it's comparable with many other OPR professions. And this would, I should note, this is operating as a board structure, and so within the OPR professional regulatory fee funds, boards are kind of their own structure. So revenue that's raised by their fees pays for the expenses of the board in regulating the profession. It's not shared across other professions like advisor professions are.
Okay, that's helpful. Okay. Any questions or anything else you want to tell us about the fiscal impact of these new licenses?
One other piece of context that may be helpful for a state-by-state comparison is that this would be the first sector that regulates early childhood educators. As far as I know, Vermont would be the first state to regulate them in this way.
And maybe it's not a question for you, but I mean, somebody else in the room probably knows, is the connection between the licenses and the, like, CFAP or the other early, childcare programs that we have. Is there anywhere where there's a direct connection, or we're just kind of assuming there's going to be a connection? You know what I mean?
Not quite. Is there another?
Yeah, it would be kind of like, is there any regulations in any of our other childcare, early educator, or early education bills that would require a licensure? Like you could you're eligible to get CFAP help if you're having the licenses.
Katie McLean, Legislative Council. I'm not sure if I'm quite answering your question, but these licenses are specific to the Child Development Division. So they would be in programs, specific to programs that are receiving CCFAP.
Okay.
And a private program could choose not to receive CCFAP.
But to receive CCFAP, you would need to have the staff be licensed.
Well, if you're working in a CDD program, yes, you'd have to be licensed.
Right.
So, yeah.
So there's that. Okay. Okay. I don't have any other questions. Thank you. Does anybody else on the committee have questions for Barnett or for Jenny or Senator Lyons? One of the three.
If I'm understanding correctly, so the ask for this year is 262,000. But then down at the bottom, it says these positions would approximately cost additionally 370,000 annually starting next year. And I guess that was kind of my question, because it sounds like as the fees ramp up, it pays for itself. So in the interim, it's like we need to fund it from the general fund to get it up and running. So this year, so why is it more, it sounds like it's slightly more expensive next year? Is that because of the additional staff? Is that, okay.
And as you get closer to the program being operational, right, they're imagining adding additional staff to get prepared for the profession being regulated. I will note that this is information pulled from their Sunrise assessment. I can't, when OPR comes back next year, they may realize that they need a different set of resources. Yeah, okay. Not speaking for necessarily what they for sure will need in fiscal year 28.
Okay, thank you. So I asked Councilor McLean to draft an amendment. So Katie, if you want to switch with Mr. Barnett and describe this amendment you drafted. I had one question about it. It's also on our website.
So here's the amendment. This adds a new section to the bill. As you know, the bill has an appropriation section to it. So this says that the duty to implement the appropriation section is contingent upon the appropriation of funds in fiscal year 27 from the general fund to OPR for that purpose.
And, okay, so this, when it says the duty to implement 6, it's not only the appropriation, it is the staff. So it would mean they don't have to hire the staff as well.
Yeah, both would be covered in that piece.
Right. Okay, that was my other question, but now that I read section 6, I see that that's in there, so. Any comments, questions, concerns about this amendment?
I guess I have a question. So if it's just section 6 that becomes contingent on the funding, I mean, I hope that we fund this. I hope that we do it. But should we not, thinking about the implications for the other sections?
So I'm looking at the effective dates in the underlying bill. So what would take effect this year would be the first section that adds early childhood educators to the list of professions OPR regulates. The board for the new early childhood educator board would be effective, and you have a reporting requirement. So those are the pieces that would take effect this year, but the actual regulation wouldn't start taking effect till July 1, 28. So
it could theoretically, if for whatever reason, if it didn't get funded this year, it could be funded next year.
It could be, with the exception that substantively have the board being set up or authorized this year with no positions funded in it. So that would be that'd be the.
Would they be required to set up the board?
Yeah.
Who sets up the board, OPR?
I mean, if you're putting into effect the board on a certain date, but you don't have any positions to do it, I mean, then you have a regulation in place to do something, but not the position to do it. So you could, let's see, if we want to change the amendment, you could you could just say the duty to implement this act instead of section 6 of this act.
The board
and
could
then-
be established and they could meet. They could adopt rules, but I guess they wouldn't want to do that without staff to help them.
One of the positions is the executive director of the board. Let me go back to section 6. Sorry, I'm flipping between two documents. So the two positions, one full-time classified executive officer of the Vermont board, and then a full-time exempt staff attorney. So you wouldn't have that executive officer of the board. So I guess in theory, there could be a board without the executive officer. I don't know how that would work. You do have OPR in the room, who I'm sure would love to tell you about how that would work.
Beth, if you introduce yourself for the record and.
Jennifer Cole, the Director of the Office of Professional Regulation. Hello, thanks for inviting me to speak. So this is going to be a program that takes extensive work to set up. We're talking about 5,000 to 7,000 licensees. And the reason we asked for an implementation date of July 1 of 28 is because we need 2 years of significant work to be able to do this.
Yeah.
And we need a general counsel staff attorney and an EO to help us in that work.
Yeah.
We're going to be doing extensive collaboration with the CDD division and other state agencies and stakeholders, because right now the requirements of people who are working in state regulated childcare settings, it's a very complicated system right now, and we're going to have to untangle that and work with these partners to implement. And we don't have the resources without these positions to be able to do that work.
Yeah. Understood. Appreciate that extra context, but the question is, we're gonna remove the appropriation. Would you also want us to remove it contingent on funding? Because we're not gonna decide on the funding today, so we're gonna take that funding out. And then we could either also take out, so right now, our amendment will take out the funding and the two positions. That's the core part of the appropriations. But there's also the section saying the board should be set up.
Yes.
We could also make that contingent on the funding, or we could leave that in, and the board could be set up, but they would just kind of, if for some reason we didn't fund it, the board would just kind of sit there without any staff.
I think we can leave it in there and not contingent on the funding, setting up the board. I mean, we do need the staff, but I think we can leave that in there.
Okay,
Find a creative way to do it.
okay, well, given that, if there's no other questions or comments, I would entertain a motion to move the bill favorably, or amend the bill and then move it favorably.
I'll move that we amend the bill with draft 1.1 of the proposed amendment for S206. So that's just amending the bill.
Okay, the clerk can clerk away, unless there's comments on the motion. Comments, questions, debate.
I thought it was well done.
Oh, thank you.
Is it a motion?
Yeah.
Yeah. Very well done. It was very official. Okay,
What's that?
yeah, I'll set.
All right.
Practice today.
That's 206, Bill, Senator Baruch.
Yes.
Senator Brennan, yes. Senator Lyons.
Yes.
Senator Norris.
Yep.
Senator Watson.
Yes.
Senator Westman.
Yes.
Senator Perchlik.
Yes.
Great.
Okay.
So
I assume
I
we
would-
have a,
You want me to make a motion?
I included it all in your motion.
Oh, shucks.
Well, I
Okay.
think at least.
To amend.
Very well done.
We amended and moved it at the same time, but you can volunteer to report it on the floor if you want. I just volunteered.
With hesitation, yeah, I'm glad to do it.
Yeah. Okay, wonderful. Okay,
What was the vote?
we succeeded in passing S206.
Was the vote 7-0?
Now we will move to S219. This is the act relating to Energy Navigator program that we talked about. We had an amendment drafted by Ellen Chakowski, who cannot be here, so I will explain it together maybe with Hold on, I guess I have mine. So there are 3 instances of amendment.
Thank you.
The first 2, if you remember, there was things that the navigation report had to do, and we thought the wording in a couple of them were weird. They just said like, fund the program, and we said they provide recommendations for how to fund the program. And the second amendment is similar. Instead of just like grant funds, we're saying recommend grant funds. And then the third is the typical contingent language on the back page, which is saying we're going to remove section 2, which is the appropriation, and to say that they don't have to do that section unless they're funded for it. We went back and forth with Councilor Chakowski a couple times on this, and is there any questions, comments? Do you want to say anything about this?
Nope, I think this works.
Okay, so with that, we'll entertain a motion to amend and pass favorably S219. Okay. Do you have a speech to give about your motion? So this is a motion to move S219, well, to amend it by draft 2.2 and pass it favorably.
Keep your favorite.
Keep me in.
I'll set the roll.
Well, I'll
Rock and roll.
rock and call roll.
Senator Baruth.
Yes.
Senator Brennan, yes. Senator Lyons.
Yes.
Senator Norris.
Yes.
Senator Watson.
Yes.
Senator Westman.
Yes.
Senator Perchlik.
Yes.
Reporter.
Senator
Oh,
Watson.
sure, yeah, that's. I guess.
Our current clerk is so collegial compared to our former clerk.
Yeah,
There are so many instances of
I know.
my vote being denied
Yeah.
on the old clerk.
I think that the bill that we passed on the floor was
We just passed that.
right because
Prevent guys looking
our former clerk would not tell people when the vote is or where to vote, call them.
Former clerk, would you hand this to the committee assistant?
Thank you, sir.
Providing false information.
He's thinking of something, but he can't come up.
Diluting the purity of my vote.
All right, I gotta hit the road. Everybody have a good weekend here.
Okay.
Right?
You too.
Oh, boy.
Good one.
Got the votes through. So we have EDH.
Mediation, like 6 minutes.
Okay, so we will take a break or go on mute. One of the two. This is Senate Transportation, March 13th.
Appropriations.
What did I say, transportation? It's almost
If
a
it's
forum.
transportation, I'm in the wrong spot.
There's a lot of health issues we're dealing with.
Well, majority of the people at the table are transportation.
Yeah, this is a quorum of the transportation.
Absolutely.
So it's sort of, well,
What are the rules around us meeting outside of?
You can't make any decisions,
nor talk about
can't
transportation.
talk about transportation.
Okay, so just.
Too late.
That-
So when we
you
get to the
automatically have been
transportation,
ethically
We'll have
disqualified.
them up on charges.
transportation budget and the numbers incorporated into
there
the
you go.
budget, we can't talk.
One of you
Nor
has
can
gotta
we
be
talk about
absent.
appropriations when we're all on transportation. Okay, so with that out of the way, glad we got that settled. We're going through FY27 budget presentations. We have the Vermont Department of Health with us today, so I'll let you introduce yourself for the record and give us your presentation.
Sure, Rick Hildebrand, Commissioner for the Department of Health, for the record. I am joined today as well by Megan Hope,
Financial Director.
and she's gonna tap in at the relevant point and give you much more meat than I will in numbers. Go to the next slide, Megan. Maybe. There it is. All right, so it's okay. I always start by just presenting our mission and vision and values to reconfirm our commitment to Vermonters, that we stand by them in these challenging times, in this challenging space.
Well, I'd like that you have data as one of your values.
Yes, it is. I'll touch on that briefly, but data is a big part of what we do at the health department. Health consists of 616 positions across our central office and our 12 district offices. I always reference this we call it the chiclet diagram, because it reminds me how much we do. It's a very broad department that touches many parts of our lives here in Vermont. And that can be very diverse, from very concrete clinical work, like the Office of the Chief Medical Examiner, nursing home visits for new families and laboratory testing, to much more public health things, such as community-based chronic disease prevention, health promotion, environmental health, looking at water and air quality, food safety. We have experts in all these fields. I am not an expert in all these fields, but we do have experts in all these fields that we can rely on to help us in these areas. And if ever there is a need to speak with a subject matter expert, I can certainly have them in this committee or in others. So, as you mentioned, we do have data as one of our values, and because we love data, the health department also does a lot of things with data, including having our strategic plan with a scorecard. We are responsible for convening and compiling the state health improvement plan, the state health assessment, Healthy Vermonters 2030 dashboard, as well as many other reports. This isn't intended for me to read this off, but it's there for your reference if you'd like to review them. But we do have a lot of data projects that we work on. As you heard from AHS, our budget process this year was very different. It's my first time taking part in the budget process, but it was very different, where we took a holistic approach to the budget, and we didn't just look in the silos of each of our departments. That meant, and we knew we were looking at a $75 million sort of shortfall, that we had to make some challenging decisions in this budgeting process. We did have prioritization of programs. With some keys in that process, we were looking at services, we were looking at housing, and a number of other things that we wanted to ensure that we kept. It was challenging, for sure, at times, especially we felt that in the department, but we felt strongly that if we looked at this all together, we could make the right decision for Vermonters. There's not a lot of ups in our budget, and we did work with the Opioid Settlement Advisory Council for increases in substance use disorder treatment, and we'll be working on rural health transformation projects as well, where we'll have some focused efforts.
Is that based in another department as you're just involved?
Rural health transformation?
Yeah, what department?
So the central office is the coordinator of the rural health transformation projects. Each department has been assigned some projects because they're relevant to their areas. Some of them are frankly gray, and we share those between departments. But as an example, workforce development, we do a lot of workforce development work, so we took up the primary lead on those projects. A couple other ones, the substance use disorder, things would be in our realm as well. So. All right, so fiscal year 27 governor's recommended budget. Our budget this year is just over $221 million. That is a decrease from fiscal year 26 of about 1.2%. Federal funding is the largest source of funding for our departments and programs. General funds account for 11% of the budget, and when you include the state share of global commitment, it's 22% in totality of our budget.
And your overall budget, maybe this is on the sheets later. Can you give me the percentage from FY 26 to FY 26?
It's down 1.2%.
Down.
Yeah. Compared to 26, our global commitment budget is.
Senator Lyons.
No, I'm not gonna ask it. I'll save it.
I'll do it. But Senator Watson.
I do have a question. Sorry, maybe you're gonna talk about the interdepartmental transfers?
Megan is going to talk about the interdepartmental.
Oh, okay.
I'm sure you want her to answer those questions when it comes to technical money transfer stuff, but she will be.
Okay, well, if you're going to be talking about it anyway, I'll just hold the question. Okay.
So we do have a lower global commitment request of $5 million, federal global commitment request this year, and our federal receipts are also projected to be $1.1 million lower. All right, so why do we have some lower budgets and lower requests? Well, again, challenging decisions we had to make this year, and we did elect to recommend cutting a few programs. I'll start with the maybe the easiest, I don't know, the most straightforward is the discontinuing the efforts to implement the unused drug repository. We have tried to implement this program for a couple of years. We had an appropriation to essentially collect unused drugs and repackage them. We have not been able to find a vendor that would be willing to do that. It's essentially would require more funding than is in the budget, and we were unsuccessful. So we recommend, we never started it, we recommend not continuing that going forward. And the second two are in workforce development, and I will go into a little more detail in the next couple of slides, but the Health Professionals Educational Assistance Program, which is $4.1 million, and the Area Health Education Center Program Support, which is $550,000.
So you're going to describe those?
Yes. So
Yes, Senator.
So you're going to describe what you're gonna do in replacement of them, or?
we're not going to replace them. We cannot replace
Well,
the programs.
the terminology may not be
I
correct.
understand.
But in a number of the areas that are
Yep.
workforce related,
Yep.
in the rural healthcare, the federal grant, the
Yep.
big federal grant, they're doing alternatives to that. Are they doing alternatives to that?
Right, so, and I will get into that. Our HTP program has opportunities for workforce development. They are not the same. And it's
I
definitely
understand
different.
they're not the same. I'm asking the question, is there some alternative to those that are proposed?
Yeah, so it's not in our proposal. We did not go into detail with RHTP in this.
Yeah, I understand they're not.
Yep.
What I'm asking is if there are going to be, in the overall proposal in the governor's
Yep.
budget,
Yep.
and with that grant, if there are alternatives, I think for us to be accepting as a group of that, we have to know, what we're gonna be doing in the workforce area to be able to be accepting of, some reduction in the area.
I completely understand what you're saying. And I do want to share that information with you. I don't have slides to that here today. I can talk about it in some generalities, and we can absolutely get into more
Well,
details.
on Monday, when you and I
Yes.
sit down, I'm going to want, that information because this committee, particularly, Senator Lyons will be asking.
Yes, and I absolutely want to go through that.
I think,
Is that not right?
You are right.
yeah, I think it's important for Dr. Hildebrand to know that, this committee worked hard to get that money.
Yep.
For that program. So before we just agree to cut it, we want to know the reason why we should cut it.
Right, I completely agree with that. And this is, again, no one had easy decisions to make this year. And I think we could all agree if we had, budgetary allotments, we would want to continue both of these, right? I don't think anyone would argue with that. We made some very hard decisions in our budget across all of AHS, and this is not one that we wanted to have go below our line. So the sort of two main workforce development programs we have. One is with VSAC, where essentially it is used for loan forgiveness for a number of health professions. It primarily does go to nursing, so it's a $4.2 million grant. 3.4 million of that goes to nursing. 420,000 is to primary care providers, both MDDOs, NPs, and PAs. Dentists is about 190,000, and dental hygienists is 100,000. And again, in this proposal, it is proposing to cut that. The second program is AHAC, which is the Area Health Education Fund, Area Health Education Centers, which is $500,000 for supporting the operations of them, which are primarily targeted at getting folks to go into healthcare professions and lower levels of education, so in high school and that sort of thing, to encourage them to go into health professions. And then there's a $50,000 grant for UVM medical students and medical residents to work. So a smaller percentage of that goes specifically to medical students. And again, the third thing that I had already mentioned is the unused drug repository. So those are the three sort of proposed budgetary programmatic cuts. And again, we'll absolutely work with you and explain what RHTP is and what it isn't. You know, broadly speaking, it's a lot of money for workforce development. It's not all tuition reimbursement. Okay, some of the programs are looking at workforce, what they're calling residency programs, which is more like job training for professions. I can tell you, me personally, we do this down in Rutland. We have a nurse residency training program, which is designed for new grad nurses to develop comfort and caring for folks. It's very well received and does provide a lot of help and support for new nurses, and looking at that in other fields. That's not a tuition program. There are others that are looking at scholarships though, specifically to help with the cost of education. There are some specifics in the programs about what it allows and what it doesn't allow, and I think I had mentioned this the other day. It does not allow for physicians, nurse practitioners, or PAs explicitly in that, which is, you know, again, something we currently do fund, and it is not allowable in that. But there's also, it's an opportunity for us as a state, because it is a significant amount of funding that we would like to leverage over the time frame of that program.
You could answer this one. Something like that, some of the hospital, I don't know if you're doing this around, but that are doing inside the hospital training to get somebody from to become an RN or, you know, like, would that be some kind of workforce that could be supported, like providing hospital funds to either increase or start up those types of programs?
Sort of depends. So if it's, you know, partnered with a educational, you know, institution, a university, there is the opportunity to have, again, tuition scholarship programs as part of RHTP, and that could absolutely be through that pathway. And there's a critical occupations scholarship program as well for some of those challenging to recruit, you know, things that we have here in Vermont. One I've learned a bit about is around dental hygienists. We do not have enough dental hygienists in this state. I was able to go to the Burlington FQHC, and they've got this beautiful dental clinic that's staffed entirely with dentists. They can't get any dental hygienists there, which is mind-blowing but true. There's a lot of needs in workforce development. It's nursing, it's ancillary services, it's of course in physicians. There's many gaps that we have. All right. I was gonna pass it off to Megan to take it from here, and I'll step back.
I just have one question.
Yes.
So going back up to the cuts to AHEC, which is really, has been a significant program for 40 years?
A long time.
Yeah. How, is it ineffective?
That is a great question that I do not have great answers for. I would strongly encourage the committee to hear from AHEC and hear what their outcomes are related to that program, because the truth is our desire to have an effective tuition reimbursement or tuition scholarship program or whatever our workforce development program is that keeps people in Vermont practicing for long term. And that is exactly what we want to develop going forward, and I would ask AHEC for sure about what their outcomes are.
To in my understanding and from my work with AHEC, that's exactly what AHEC has been doing. So it'll be interesting to hear more about the rationale.
Yeah, and to follow that up, when, we're gonna need in here the information, what's covered now, what's not going to be covered in the envisioned new world.
Absolutely. Completely understand. It's a challenging decision that you all have to make, and I want to provide you with as much information as I can.
Thank you.
Megan?
And for the record, Megan Hope, Financial Director of Health. I'm gonna take you all through our ups and downs. So the Health Department will, if you have the AHS ups and downs, we're on page 10. We have 3 separate appropriations, starting with section B 311 for our admin appropriation. Happy to take questions throughout. Just let me know, feel free to stop me. In admin, you'll see we have our net changes for salary and fringe for all of our employees. There are 59 positions in fiscal year 2027 compared to 62 in 26. 2 of the positions are now in our public health appropriations, just kind of an internal shift as to where those positions are reporting. And 1 position has left the department due to the cancellation of the federal health disparities grant. So that
The
overall,
person is left, or you're getting rid of
the position was eliminated because that federal grant was terminated. So that those net changes in positions explain are the main difference between our salary and fringe costs from this year to last.
Okay.
This next slide shows changes in our internal service charges from 26 to 27. The biggest item you'll see, and that I know the agency has touched on, the largest increase we have is in our ADS allocated charges, and that's due to just a shift in how those costs are being billed to the agency and then departments.
Did you see it down in ADS's like SLA charge or something?
We're expecting to see fewer SLA charges come through and more costs coming directly to this ADS allocated charge. So that's why there's an increase there, and we're budgeting less for that SLA.
Okay.
And then next slide here, we have changes to our grants section, and this is where the first 3 lines are.
Already.
Yes, so it does look a little bit alarming. I will try and comfort you that the first 3 lines reflect the move of our rural health and primary care programs from the administration appropriation into public health. That was, again, those programs are not being eliminated. You'll see a positive side on the public health appropriation. It was really just, again, internal. Those programs are much more suited and better operated within our public health appropriation than out of the commissioner's office. So that's those first 3 lines. The next 3 lines, you will see the area health education center, education loan repayment, and those 2 are the program eliminations that Dr. Hildebrand mentioned.
So those are gone.
Yeah, those are gone. I will make
They're proposing them.
or yes, sorry.
We get it at the time.
Good thing you said that.
Just a small note, the education loan repayment line, the $250,000 federal item is continuing in the Public Health Administration. That's the state loan repayment grant that comes from to the health department from HRSA. So that is not, we
That's
anticipate
$250,000.
continuing to receive that grant.
And it would be for those 3 professions that were on that BSAC slide.
Yeah.
Yes, Senator Westbrook.
Do you have any, can you tell us how much is envisioned in the rural health transformation grants? How much money within the broader area of workforce development that would be covered, not exactly by this, but roughly how much many resources are gonna?
I believe the rough budget for rural health transformation is about $10 million for workforce, dedicated to workforce.
And is that specifically related to here, or are you talking about everything? Because there is there's dollars in for example, in Dale, for nursing, for recruitment around, nursing homes. So am I talking apples to apples, or what am I talking?
In terms of, I know for the health department's budget, this education loan repayment program was geared towards, nurses, physicians, dentists, dental hygienists. And my understanding of the rural health transformation grant is obviously very much still in flux as we negotiate with CMS, but that workforce money is for broad, healthcare workforce.
I know there's some primary care.
Yes.
And,
Yep.
yeah. So, and along the lines, because trying to coordinate what's happening with RHT and then what's continuing in the state, and then we know we can't replace or supplant what's here. But if we eliminate all this stuff, or some of it, then we don't have a program. Does it then become eligible for rural health transformation grant dollars?
Again, we can't replace the existing program. With RHTP, we're looking to.
Yeah.
Cannot be used for loan repayment. It's listed in the rules of RHTP.
That's right.
So we would have to redesign it anyway, because it can be used for concurrent or scholarship programs. And we don't have to sort of cancel one and restart, but we can't use it for loan repayment. Which is a lot of, again, the VSAT.
Understood.
Yeah.
The details of both sides will be good. I would just say to you, in the there presently is a program of about 600,000 helping nursing homes with the recruitment of RNs coming out, and the replacement not replacement, but the new program that in the rural transformation grant is about an $810,000 program, and I'm trying to figure out what each looks like. Understanding what you say, 10 million, and I'm looking here that, I'm probably looking, well, I just lost my page, but it's probably, 5.3 here, and just to get a feel, I'm just trying to understand the two.
Okay. Continuing on, any last questions on grants? Okay.
We'll be back to it.
Yeah, I'm sure. So now we're moving on to our public health appropriations, section B312. And again, here are major changes in our salary and fringe compared year over year. So in public health, there are 510 positions in the 2027 budget compared to 513 in 26. So we have a net reduction of 3 positions. And if you want, I can give you kind of the ins and outs. There's a few, as I mentioned previously, 2 positions moved into this appropriation from our admin appropriation. 11 positions moved into this appropriation from our substance use appropriation. And then we had 1 new position, and then a total reduction of 17 positions. And those 17 positions were funded federally. 13 were related to COVID response supplements that the department had received over the years. 2 positions were that health disparities grant that was terminated last two years ago in the spring. And then 2 positions where the work itself had ended. So lots of information. Happy to repeat any of that if needed.
That's good.
And then maybe if you have, at some point, like if you have all those positions on one sheet, kind of like the whole department.
We do, yes. In our supplemental materials, there is the full list of all the positions, but not, it's only the positions that are included in the budget. We can get you something if you're looking for the
kind of the ups and downs.
Yeah.
And when you do that, if in how much of these are just shifts and empty positions now, and what's filled, what's not, and because Because I suspect most of these aren't filled positions.
Of the positions that were eliminated, 7 were vacant, so that we reduced them via attrition, whereas 10 actually had to be ripped.
And of those 10 rifted ones, how many were, there was a person in that position?
Yes,
All 10.
10, yeah.
Then that's already happened, or you would?
It has happened.
Okay.
And so you would have the numbers on how many were offered other positions in state government.
Oh, that might, I'm not sure we would have that information readily available. That might be with the Department of Human
HR.
Resources, yeah. Our next major changes to the public health appropriation, again, this first line, the no unused drug repository, that is the program that the commissioner was speaking about earlier, where it really hadn't started. So one of our easier areas to identify savings this fiscal year was to stop pursuing that agreement. And then the last 2 items in our operating expenses are fee for space charges, so increase in our district office space rent costs, and then the medical and lab supplies line, that is a move of our Narcan program from public health into the substance use program. So again, it's a down in public health, but you'll see a corresponding up in substance use disorder. That program is still continuing, just in a different appropriation. And for our grants line, again, this is where I promised corresponding ups, here they are. The move of those rural health system improvement and clinical development and support, along with healthcare quality assurance, education loan repayment, and quality improvement prescribing. All of those that were removed from administration are now landing here in public health. And then finally, for our public health appropriation changes and subrecipient grants, our immunization line reflects a requested budget increase of about 7.5% of the cost for the Vermont Vaccine Purchasing Program. This program ensures universal access to vaccines for all people in Vermont at no charge to the individual, and the program helps reduce total cost of vaccine by using our volume purchasing contracts. The program costs are funded by an assessment to health insurers, which is then deposited in a special fund and used solely for administering the program. So that is a request and increased spending authority, so we can utilize that, the revenues received in that special fund. Our next line, the HIV/AIDS service, this was that syringe service program that I noted. It is I'm sorry, I noted Narcan. I didn't note syringe service. This, again, is another program that it was in our public health. We're moving it to substance use disorder, so you'll see an increase there. The maternal and child health program grants, the first IDT line, this is an anticipated reduction in what is federal grant revenue to DCF that is coming to the health department for the PDG grant, the preschool development program. DCF is still receiving that grant next year. However, just kind of the shift in who is doing the work between BDH and DCF is adjusting, and therefore DCF is kind of taking on more of that work than the health department. So we anticipate a reduction in.
So it's kind of neutral, but between 2 departments.
Yes. The next MCH program line, this is a move of the school Medicaid administration claiming program from the health department to the Department of Vermont Health Access. They will be taking over that program with the help of the with Agency of Education in the coming year. Our tobacco control program, this is really a budget neutral change. The source of funding for the program is in the budget, we're truing up the sources of funding to more closely match how we actually spend the dollars for this program.
It's not coming from the tobacco fund specifically, it's going to come from federal funds.
We're anticipating a little bit more spending of federal funds in in this program in the year, and our tobacco spending is going to be even over our MSA spending is gonna be even, but just for grants specifically, more of the subrecipient grant money going out has been historically our CDC grant, so we're kind of truing up the funding of this line.
Do you have anywhere, just like a page on the tobacco funds?
We do, I know our substance use prevention programs was working on, putting together a pager of prevention spending, and it includes tobacco.
Okay, good.
And I just talked with you about that the other day.
Okay, yeah, we'll be interested in that when that's ready.
Yeah. And then finally, the emergency medical services line. This is a request to increase spending authority in the emergency medical services special fund. That fund receives a transfer from the fire safety special fund every year. And back in 2024, Act 113, the amount of that transfer from the fire safety fund into the EMS fund increased, but this is kind of a cleanup item. We just now need the increased spending authority in order to spend those dollars.
Okay.
That is the last slide for public health. Wondering, a pause here, any questions about our public health appropriation? Okay. And finally, our substance use programs appropriation. Net changes in salary fringe costs. There's an overall reduction here because of those 11 field-based staff that moved from our substance use program into the public health appropriation. So overall 47 positions in 27 compared to 57 in 26. So those 11 positions that moved, and then we actually had one additional position in this appropriation.
Okay.
And then for our operating costs, this is that Narcan distribution program that moved out of public health and is now in substance use appropriation. Just an internal shift. And then finally, our grants. And I'm going to just touch briefly on substance use prevention, and then I'm going to turn it back over to the commissioner because we have some more talking points for you all on that. But essentially, our substance use prevention has an overall increase, and that increase is from the Substance Misuse Prevention Special Fund, and that is funded by the cannabis excise tax, in which 30% up to $10 million comes and is transferred into the Substance Misuse Prevention Fund. Overall, the administration in 27 had about just under 7 million anticipated going into that fund, where compared to 9.5 million in 27. So that's the roughly $2 million increase you see. And I'll leave it at that. We have much more in-depth prevention messaging coming for you. The next, this substance use intervention line, that is the syringe service program that was moved from our public health appropriation into DSU. And for substance use treatment, that is, again, a similar change in kind of how we're aligning our budget with how we've been spending the funding. We anticipate having some savings on our global commitment treatment investment and being able to spend more substance abuse block grant dollars from SAMHSA in this line. So a shift in how that funding is happening for the program. There is no reduction in overall treatment budget, just kind of a shift in where we're able to spend our funding there. And then our last line is the certified community-based integrated health centers. And this is funding that is going from the health department to the Department of Mental Health for those providers that will previously have been paid by the health department, but will now be paid by the Department of Mental Health. And if there's no other questions on here, I will turn it back over to the commissioner for some information about prevention.
It might be a good time for you to just very quickly in the substance prevention piece, talk about this is the first year we've really got I think 5 councils set up and so it might be a good time to just speak to the committee quickly about where we are in that process.
Yes, and that is what Dr. Hildebrand is about to do.
So, thank you for setting me up so well. Our Vermont prevention model, so prevention is something that's, I've seen a lot of interest amongst the legislature about, and frankly, something I've been educating myself on. It's not one program, not one activity. It's a combination of actions that's sustained over time to prevent or reduce something that's as pervasive as substance use disorder, alcohol, tobacco. For them to succeed, they have to reach people holistically in environments where they live, their individual, their family, their school, their community, and their state. And this is our this depiction of this holistic framework. As we had previously noted, the funding for this comes from the Substance Misuse Fund, which is estimated to be $9.5 million. And we have 3 categories where we use those funds. One is in the Vermont Prevention Lead Organizations, or VPLOs, and that's $5 million. $3 million goes into school-based prevention initiatives, and $1.5 million is prevention consultant staff that are in our 12 district offices for staffing. And I'm going to talk a little bit more about the VPLOs. So the VPLOs are our 4 established Vermont Prevention Lead Organizations that were established in 23 to serve as the fiscal agents for community organizations to lead and expand prevention efforts in the region. The intent here is to have it be based in the communities and in the regions and not centrally located. It's a competitive process, and we have 66 sub-recipients statewide that are getting grants through the VPL process. They first start by gathering data to inform their decisions. They develop a strategic plan, and then they have a competitive process to address the needs that were identified in that strategic plan, and then the board will allocate the fund based on it. So this has been was developed through an 11-month planning process with ongoing stakeholder input, and it helps preserve these dollars again in the local regions to try and address the local needs, which may be different from region to region. I've been very impressed with the way this process has gone and the competitive nature of it and how it directs the funds to where the identified needs are within the data and the strategic plan. So broadly speaking, that's sort of where we stand right now. And our hope is to have more outcomes related to the initiatives, because as you had mentioned, they're really just getting going. Okay.
Only because a lot of the effort around that centered around the work that Senator Lyons, Kitchell, and Sears all put in, and a lot of work that was put in this committee.
So one question I always ask, and I know that Emily, and I forget her last name.
Emily Truder?
Yes. Yeah, are the savings that we accrue from the prevention work that we do. And so I know it's always, you put $1 in, we get $13 back.
Yep.
Is it possible to get some estimate of the benefit that we've received as a result of all this prevention work?
So we are developing a slide deck that will specifically.
I keep asking, so it's coming soon.
And we've been working on it for a couple of months now.
Good.
And I am pushing them to give you exactly that, because we can tell you how much money we spend in prevention. I want to know as much as we can tell you about, hey, this is the impact that it's made. It's obviously hard. This is hard work and it occurs over decades, but to the extent that we can give you, hey, here's the difference that it's made with this investment, that's what I want to give you.
That would be great, because it's so, it's fuzzy to people. Right. They don't, so they'd rather go out and solve the problem where it is right now rather than take a look upstream and sort it out for later.
Yes, Senator Watson.
Thank you. How old is this program?
The VPLOs were established in 23.
Okay, so not a lot of years of data, but I'm sort of to that point, it would be interesting to see the graph over time, the return, as a ratio or, savings, just because playing that out long-term, I can imagine it'd be like flattening, but I don't know that there's any flattening yet.
Right,
So.
and I mean, a
so
lot of
soon.
this savings is in cost of living, so this is challenging stuff to sort of definitively have a
Sure.
straight line, like, here's what's
Yes.
happening, right?
Right.
But that is exactly what I'm pushing my team to do, is say, hey, I need to show to you all, here's what we're getting from our investment, okay? I know from the folks who work on the ground, that how impactful they see their work to be, but we really do want to show, to the extent that we can, here's the financial impact of these investments, of this investment.
It passed in 23, but the councils are really much newer. They're within the last 2 years.
Okay, that's
And-
like, that's
and
barely a
the
trend line.
the whole upshot of that is the effort was to get the prevention stuff back in the communities and out of, and the councils were set up to give them the ability to pull people from regions in to make this as close as.
Seems great.
Right, because I mean, clearly, you're gonna have different things that you need in Burlington versus the Northeast Kingdom versus that. I mean, they're different communities and they need different things, and that's, I think, the beauty of this structure.
Great.
I don't know if you were gonna try to.
I was gonna say, if you want, we do have some time. I'm happy to go through some of our appendix documents that we created to try and address the additional requests for information, but.
Unless there's something specific, but I appreciate that you responded to our letter that we sent in October. Not all departments do. We should give the other departments a hard time, but I just want to give you a gold star for doing them all. So the committee should look at these pages 47 to 48. But on page 29, you do have to talk about the position changes. But it
Yes,
says that there are no position cuts, but then it talks about reductions, so that's why
So
it's
in
confusing.
in 27, we didn't make any cuts, but the changes in the ups and downs were a difference between what was in the 26 budget and what was in 27. So I can see how you have a question about that. It's,
So if there's another way to lay that all out, to be
Yes.
more clear. And then the very
Yep.
last slide, right there, where you talk about your special funds, you had a health department special fund,
yes, we do.
21902, what is that?
Honestly, it's kind of a catch-all.
Okay.
A number of programs go there. For example, our newborn screening fees, where hospitals pay for the little blood prick that each newborn gets, and then we send off to, I believe, Boston. I'm a financial person,
Sure.
not a program person, but we collect the fees from hospitals to do that and then run the program. That, for example, is something that runs through the health department special fund.
So like that whole program runs out of the special fund, both the funds coming in and the
Yes.
costs going out?
Yep, correct. Some other things that go into the health department special fund. I'm blanking, but there's a whole mix.
Whole bunch of things,
Yes.
kind of your miscellaneous account code for
Yeah,
both.
it's our miscellaneous fund.
Can I ask one more question?
Yeah, of course.
So one of the things that we're looking at in our committee, we have been looking at since January, are the number of reports that we get from folks. And we've asked for recommendations about eliminating some of those reports. I find that they're very valuable, but some are not valuable. So it would be helpful when you have a minute, help with that.
Absolutely.
Would be great.
Especially if there's any reports that you're like, this takes a lot of time, and we're not sure anybody reads it.
Correct. That we will make sure to highlight those specifically, that these are a questionable benefit or value.
Or that'll take a lot of time.
Yes.
You're like, the time benefit ratio.
Or they're out of date, yeah, someone just has.
Senator Watson.
Actually, I can ask this question offline. I have some interest in the lead and asbestos abatement fees and where they come from, but I can ask you another time.
I will have an email to you, saying how I want stuff presented and what I need on Monday.
Yeah, absolutely.
Yeah, it may not be till tomorrow morning, but that's okay. I'm working on it.
Okay. Well, thank you for your time, both of you.
Thank you. Thank you.
Good work. Okay, we will.
The image is here, you can start.
No, well, we don't need to take a break. I don't think so. We've already picked a break. Only one break a day.
Um,
Are they out in the hallway or are they online?
And
I have one person
thank you
online,
for taking
Okay.
the
So we could just mute.
speed trap.
Sorry, 224.
We are off mute.
Okay.
Center appropriations, FY 27, Department of Mental Health. So Commissioner Hayes,
You will.
you introduce yourself and anybody else come up with you?
That one
Give
was
us your
like,
presentation.
I'm just gonna pull up my PowerPoint real quick.
Okay. You have, on your,
To that
Yes.
day, he'll donate
Easier there.
thousands of dollars to Republican officials here in the county. So, he'll get zero from it. Anonymous Christmas list.
All right. All right, good afternoon. Thank you all for having us here today. My name is Emily Hodge, and I'm the Commissioner for the Department of Mental Health.
And I'm Samantha Sweet, Deputy Commissioner of the Department of Mental Health.
Great, so real quick, wanted to provide some context of the Department of Mental Health. So as you can see, our mission is to promote equitable access for mental health services to our community. As the Secretary testified earlier this week, the Agency of Human Services went through a rigorous practice over the summer at taking a look at all of the programs within the Agency of Human Services in order to develop our budget for FY 27. From a DMH perspective, we did this work following our core values. So keeping to the front of our decision-making, compassion, equity, integrity, collaboration, and accountability. As a reminder, the department oversees 10 designated agencies. We also contract with 2 specialized service agencies, and we designate 6 hospitals across the system. We also operate the Vermont Psychiatric Care Hospital, which is a 25-bed hospital for adults here in Berlin, and the River Valley Therapeutic Residence, which is a 16-bed facility located in Essex. As a VPCH has some folks coming and going today, but typically at 21 of the 25 beds, and they've been at 21 for the past
really since COVID, that's about as high as we've been able to get from a staffing perspective. Yeah. And we do have a vacancy chart embedded within our presentation to demonstrate the progress that we've made with vacancies and hiring, but also that we're in a really challenging staffing situation, both there and River Valley. River Valley right now is topped out, I think, at 12 residents who can be admitted there. And that's a combination of staffing and there's some current construction going on there to add a seclusion and restraint suite.
Does your, where else if you talk about the staffing, do you talk about like what the need is, like how many, what's the unmet needs as far as beds go? Like if you were to fully staff, does that still leave another need for 20 beds, even if you could fill these two facilities?
We do have some data related to the number of folks presenting for involuntary care, both from the adult perspective and the youth perspective over the last years. And we have seen the wait times for treatment to have decreased in that folks for involuntary care, court orders, and most voluntary. And just a quick reminder, most folks accessing hospital level of care are voluntary. And so Vermont Psychiatric Care Hospital only serves individuals who are involuntary, and we have seen those waits decrease over time.
Good.
We also collaborate with across the mental health system, numerous hospitals. We hold the contract for forensic psychiatrists through the court. We also do psychiatric consultation on primary care. We work collaboratively with law enforcement, courts, other state agencies, you name it, we are probably collaborating in some way. Real quick, here is a slide that depicts our organizational chart at the executive level. You'll notice we have 2 vacancies, one being our finance director. So I am appreciative of Tracy O'Connell joining today. We are without Shannon Thompson, she's since retired. And then we have a vacant director of clinical operations. This next slide gets into the vacancy rates by location. And this is specific to DMH staff. So this is not an example of what's happening across the mental health system at large. This is specific to the Department of Mental Health. So as you'll see, about a year ago, DPCH was hovering in, I think that was around 45, 47% vacancies, and we've been able to bring that down. That's down from about 60% vacancies the 2 years prior. So we are making progress there.
That's good, but you're still, I think you're around Department of Correction level. No, I think they've gotten down below.
Yeah, their hiring pool is a much broader pool of individuals for psychiatric nurses. That's a specialized group of individuals who are trained specifically in both nursing and delivering that care in the psychiatric unit.
In the central office is kind of all types. Why would you account for the increase there?
Yeah, we had several retirements come to the department at the end of 2025. So we've seen a gradual shift in. A few people retired, folks have moved on to other positions where there was an opportunity for career advancement, and some are just regular open positions.
So you're expecting that to go down by 5%?
Well, I would hope so, yeah. Some of those vacancies that are listed here are already decreased, and we do post on the DMH website ongoing vacancy data related to both all of Central Office, River Valley, and DPCH. From a broader system capacity perspective, we have around 38 adult crisis beds within our designated agency system. We have youth crisis beds coming in at 18, 42 intensive residential, and 148 beds that are labeled as adult residential programming. We also have contract for 57 level 1 beds. Level 1 is how the state of Vermont defines individuals who are under the care and custody of the commissioner and who require additional resources in order to meet their treatment needs at a hospital level. Folks also have access to non-level 1, both involuntary and voluntary units across the state, as well as children and youth. This does not reflect the project that DMH has with Southwestern Vermont Medical Center to bring another youth bed online. That is still in the early contracting stages and hasn't started construction yet.
How many beds would that be?
It's 11.
Good.
So how many of the hospital beds are filled with folks who could be placed in another type of facility right now? Do you have any of that acute?
Yeah, so all individuals who are in the hospital setting are meeting hospital level of care.
So there's no one that's being held and waiting for any step down?
They're all meeting the definition for needing hospital level.
Or was that a problem before?
It has been,
Years ago.
yeah, it has been, it always ebbs and flows. And, you know, the requirements for somebody to stay at your highest level of care are scrutinized by our funders. And so we are committed to making sure that folks do not stay past their need for that level of care. And so, for instance, sometimes folks may need a hospital level of care and maybe they transition back to corrections when they no longer have that need. That's very common. And folks in corrections, if they need a hospital for their psychiatric illness, will come to the broader mental health system. And this slide is just a graphic snapshot of our complete mental health system of care. And you'll notice at the bottom, our foundation is our community mental health system. And that's the work that's happening across the designated agency system. There's private providers that serve individuals with mental health and substance use conditions. It also includes all of our mental health urgent care projects that we have done over the past couple of years. 988 crisis line, although you don't have to be in a crisis to call or text or chat 988, that's just the name of it. You can use it if you're having a hard time. And then our assessments for higher level of care. So I'll get into the good stuff and tough stuff of what we're here today to talk about. Would you prefer, I'll do a highlight, and some committees prefer the ups and downs sheet, some prefer a more narrative approach. Happy to do whatever works best for the committee.
You don't have to go line by line by the ups and downs, that's for sure. So
okay.
If you would just go through any
sure.
things you want to bring up that's in the ups and downs,
sure.
And just describe it narratively, that would be
absolutely. So from a overall funding perspective for the Department of Mental Health, you'll see that we have a governor's recommended budget of $347 million. Of that, 70% lives within our global commitment funds. And you'll see from the breakout, it also includes Medicaid investment dollars, general funds, special needs, interdepartmental, interdepartmental transfers and federal funds.
And what was it last year? Yeah, or what's the percentage change?
I believe it's Claire, were you gonna tell me?
We have it in the presentation.
It's in the appendix.
Okay, it's in one of the appendix sheets.
This next slide is a representation, same thing, but divided out by programs. So you'll see we have the adult services, that is the large darker blue at 33%. We spend about 1% on other inpatient. Vermont Psychiatric Care Hospital is a large green at 35 million. River Valley Children's Community Service, along with Success Beyond 6. I'll talk a little bit more about the PNMI rates. PNMI stands for Private Non-Medical Institution, Residential Institution, and then the department's administrative and other.
So is it slide 20 is the total numbers? That's the one you.
Oh, yes, yeah.
So whatever that, I don't know what that percentage, it'd be good if that had a percent column.
Sure.
I'll do that math later.
Thank you for not making me do that on the spot. Maybe Tracy can, because she's our finance whiz today. So I'll start briefly with an example of our ups and downs sheet. Sorry. Slide 12, please. Great. So this is also section B 314. And this is the Department of Mental Health current ups and downs. And so you'll see in here, I won't go through the salary and wages. I won't go through things like our fee for service charge or things like that show up pretty regularly. I'll call out that we still see pressures around transportation costs for youth. We talked about that, and adults, we talked about that in our BAA, as well as the evaluations related to forensic evaluations. Those are evaluations ordered by the court to determine somebody's competency. The department is required to administer pre-admission screening and resident review, which is also called the PASAR, for individuals to be determined as needing nursing home level of care. And then you'll see in here also related to a proposed reduction, which is the Team 2 training for first responders. So I'll highlight that now, and then I'll come back and talk about our package of reductions at once.
Okay.
Next, I'll highlight some grants that the department does related to our work with 988. We also have a initiative for Behavioral Health Link, which is a program designed to support centralized dispatch for enhanced mobile crisis programs. The department's bringing on additional certified community-based integrated health centers, otherwise known as CCBHCs. We'll be bringing on 5 more agencies starting in July. I have an initiative related to that. And then you'll see, excuse me, and then you'll see our rate increases related to the PNMI program. PNMI is the Private Non-Medical Institution. Those are the rate increase is related to programs within the state of Vermont. And then there's another line item that we testified about for our BAA, and that's the number of folks who receive that service out of state.
What does PNN stand for?
Yeah,
What is it, and what's the acronym?
yeah, private non-medical institution.
Okay. In the down for the reach up?
Yes, so I'm gonna move us into the downs now.
Okay.
So slide 17. So these, I mentioned the mental health training for first responders, Team 2. So Team 2 was a contract that the department engaged in to provide mental health training for first responders. We have a proposed reduction related to Team 2 of $109,000. And
Are these mental health responders? They're not all first responders?
it's not all it's anyone who is responding to a community. So it could be an emergency services clinician within an agency, it could be law enforcement, Vermont State Police, and our proposal is to take those trainings in-house. When Team 2 was developed and implemented, that was before the department had our own internal training team. And so our proposed reduction would be to end that contract. We would not take the Team 2 training into DMH, but we would be providing training done by the department to the same groups of folks.
Does that seem like a successful program?
Yeah, it has had a lot of success, and I know that first responders have been very satisfied with that program. I know that the secretary talked about that we needed to really think about what we could do internally, and this was one of those areas that would allow us to have a higher rate of consistency across our crisis programs and take that training on internally.
What happens to Team 2 as a result? They disappear?
I'm sorry?
I mean, do they disappear? Does this really eliminate them?
It eliminates the department, the DMH funding for Team 2. They could go and contract with entities on their own and still deliver that, but it does eliminate the department's funding for that program.
Okay, do you know if they have other funding right now?
I'm not sure.
Okay.
I'm not aware of that.
That's another conversation.
The next reduction comes under the bed board. So after Tropical Storm Irene occurred, we took the ability to have all of the beds across the mental health system in an electronic bed board, and that was contracted out. That contract has since ended. We have taken that bed board project internal in collaboration with ADS. That has already happened, and so this would be a $15,000 reduction.
So when you bring it in and you're reducing the budget, you're still having to do the work. So does this mean that you're adding responsibility onto one or more people who are already in one position, already doing work full-time? So now they're doing full-time plus? I'm trying to sort out how you're doing that.
Yeah, no, so we used to contract with Minnesota Hospital Association for our bed board, and then our research and stats team would take that data and run a bunch of data off from the bed board of like occupancy, beds closed for everything. And so that will continue, so no workload increase, it's just gonna continue. EDS built a state of Vermont bed board system, so that's already done, it's already running. Our research and stats team is gonna continue with reporting out on the data, so no increased workload for anybody.
Okay, and then going back to Team 2, similar question.
They have the capacity and are doing trainings now.
Okay. Thank you.
You're welcome. The next line item is the suicide initiative project management. This was project management supports related to the Governor's Challenge, which is a suicide prevention initiative. We'll still engage with the Governor's Challenge, but we'll end the contract for the project management of that. That would then be absorbed by our suicide prevention director. And they have the capacity to absorb that. The next proposed reduction is nursing services at a specific community care home, and this is a community care home in the Washington County area. As we mentioned earlier this week, we looked at equity across the system, and if one agency had one program, and this would fall under that, no other agencies are having nurses specific to community care homes. That was something that we considered to propose for a reduction. For this particular reduction, those nursing services are being considered as part of their CCBHC rate, so there wouldn't be a decrease in services for folks, but we would not be paying the capacity for that nurse at Permios in Waterbury.
So that would just put the budget pressure on Washington County Mental Health to come up with that money or change their staffing?
So Washington County Mental Health will be one of the 5 CCBHCs that come online in July. And a CCBHC requires a certain number of types of services to be delivered to the community. And one of the goals of a CCBHC is to provide integrated care, and so have a higher ability to provide services that are for medical needs. And so they would be able to shift that staff member into that rate.
Okay.
And then gets a higher federal reimbursement rate.
Okay.
The next line item for proposed reduction is community outreach in Chittenden County. The community outreach program in Chittenden County is for the broader Chittenden County areas, such as Winooski and Milton, Colchester, Essex Junction, not what's referred to as the Church Street outreach in Burlington. So this is the broader community. Our goal would be to shift the community outreach response to 988 and enhanced mobile crisis. This is another program that is specific to Chittenden County. It is not a statewide program, and was implemented before we had a 988 call, text and chat center, and was prior to the enhanced mobile crisis response.
So explain it. So are these the folks who are embedded within some of our police departments that you're talking about? The social workers who are going out in a response for an emergency that was originally established as a pilot program for the entire state? So now we're saying the rest of the state doesn't have it, so we're eliminating it? I'm trying to figure out what it is.
There is a program where there's social workers embedded within the Vermont State Police. That still exists, and this is not that. There are also other types of social work positions embedded in other local law enforcement. And it is not that program.
Okay.
These are individuals who primarily do phone interactions with folks in the community. And so we would want to shift that, those phone interactions and those community responses to the 988 and enhanced mobile crisis teams. Anything you want to add with that?
The only thing I'll add is that, well, 2 things I'll add is that we know about 35% of the community outreach is actually face-to-face. And so we see that as a pretty low percentage. And so we think that enhanced mobile crisis is 24/7. So community outreach is just a chunk of hours per town. So not even a full-time position per town. It's a few hours in these towns where enhanced mobile crisis is 24/7 access to all the towns.
This was a proposed reduction in last year's budget as well. The next up is a trio of outpatient services. DMH has dollars in our base for supporting the mental health needs of individuals on a TBI waiver. We currently serve one individual under this program. They would still be able to access mental health services. They just wouldn't have it embedded into their waiver.
Same for elder care and reach out?
Elder care is a contract that the AAAs have with the designated agencies to provide specific elder care services in their communities. Not all designated agencies provide this service, and some who can have not been able to provide the service due to staffing. And so our proposal would be to reduce the specific elder care service line for the mental health supports as a part of our FY27 reductions. If individuals in this age group needed and wanted services, they could still receive them through traditional outpatient. It just would no longer be a carved out population.
Okay.
And then the next line item is the Reach Up program. One of the lenses that we looked at when we did our budget exercise was any potential for duplicative service delivery, and Reach Up and elder care in some regards, but Reach Up is case management services that could otherwise be delivered in a different way. And so as a whole, around 300 individuals are served statewide in the Reach Up program in this way. Most of them, I think around 90%, have Medicaid, and so those are Medicaid eligible case management services. So we would shift those contacts, should they want them, away from the Reach Up program, and they would interact with the system in a traditional outpatient model. It'd no longer be a carve out. The next item on the list is.
So you're eliminating some care services and integrating it in with Medicaid. Are you at the same time moving people and moving the services so that there's a continuity of care? Or is this just a categorical cutoff?
It's not a categorical cutoff, I would say. They have individuals.
They have to go back and apply and
they would no longer be getting Reach Up case management. They would have case management that could then, address whatever needs that they have, not just under the.
Will it be a seamless conversion for them?
We can work with the agencies to ensure that occurs.
Okay.
Yeah. Sure.
Yeah, no.
And just a reminder, each agency gets a lump sum for Reach Up, and then they invoice the Department of Family and Children and Family for the individual services. And so we would shift those to billing Medicaid.
Okay.
The next line item is the Vermont Collaborative for Practice Improvement and Innovation Training. These are funds that have already ended in 2025. And we have integrated and incorporated those tasks internally across the Suicide Prevention Director and the DMH Training Coordinator.
For some of these that are like under $10,000, even though I'm really interested in puppets and education, I think you could.
Understood.
You don't have to give us
I'll
the
skip all
details.
through those. That is fine with me. I'll just highlight the larger number amounts. That's fine. It makes sense given our time. So I'll move into the Care Coordination for Children, EPSDT Medicaid admin dollars. This includes a embedded mental health clinician at the Milton Family Practice, as well as supports within Howard Center First Call. So this is a program that was implemented many years ago, and the Milton Family Practice is the only practice in the state that receives dollars for a clinician there. That practice is also a blueprint practice, and so they have opportunities to receive that same care under the blueprint. So that would be duplicative and special to that particular primary care office. The next line item is related to the Collaborative Systems Integration Project, outpatient program for justice involved. This program is specific to Washington County and was originally designed as a response to Tropical Storm Irene. They serve individuals who are involved in the criminal justice system, and those individuals are low risk, I would say, for recidivism. And so we would look to shift the specialized program to reduce that. And if individuals want to receive services through their traditional outpatient programs, they're able to do that.
And I assume that it's supposed to be a comma, not a decimal.
Yeah, I just noticed that too.
Yes.
We've only seen this about 30 times.
Following along the lines of programs that are specific to one area of the states, this next line item is related to the Safe Haven program at the Claire Martin Center for $136,000. This line
Where
item,
is that? Where's the
this Safe Haven is in Randolph. Claire Martin Center serves the Orange County and Upper 500 towns. This is a line item dedicated to support services for uninsured and non-SMIs. So is it significant or severe? Significant, severe mental illness. And those services, instead of a lump payment to the agency, would then shift to billable through Medicaid. This is an investment line item. The next line item is youth and transition investment dollars at $183,000. This is part, but not all, of the funding for YIT. This segment of funding is specific to the designated agencies. Individuals who are in this program can still receive services. They would no longer be a carve-out. Funding does remain intact for the current contract holder, Elevate Youth Services. They'll still provide them.
Let's see that.
We talked a little bit about the Vermont Psychiatric Care Hospital earlier today. You'll see that this line is a proposed reduction of 25 to 21 beds.
It eliminates 12 positions?
It does. It eliminates 12 positions.
Why would you do that?
They're vacant.
Oh, okay.
So we don't have to.
These are like, you're
Right.
trying to fill them, but you can't.
Correct. So,
Take them off the books.
right. So what the challenge at BPCH has been is we can either bring on more travel partners and open up the last unit, or leave things as they are, where we're managing the budget, bringing on more permanent, letting go of travel staff as we're able to. But because we have seen the need shift for this level of care, wait times also decrease, we feel comfortable with this proposed reduction.
Okay.
Budget downs continued. We have a transfer of funding, DMH to DCF. The IFS, or Integrated Family Services Program, we would move that program back to DCF. So it'd be an internal transfer. So it looks like a down on our sheet. There should be a co-occurring up on the other sheet.
Okay.
That's the same with the ARCH program. That's a net neutral transfer over to Dale. Also with inpatient hospital reconciliation, this is level 1 reconciliation. We have a proposed reduction at Rutland Regional Hospital, and that is that they, at the end of the yearly reconciliation, that they did not spend as much as we had projected them to spend. And then the last is lifeline suicide prevention, so a reduction to the administrative drawdown for the lifeline suicide prevention. Those activities would then be folded into the work that our suicide prevention director does. And we have confidence that they're able to do that.
Okay.
Line 20, the comparative analysis.
Yeah.
I'm happy to go through these slides, examples of grants following the requested budget submission formula, or we can answer questions in the moment.
Yeah, I think those are pretty, unless anybody has questions about, and then your $1 million carry forward for the Southern Vermont.
Yes, there is a $1 million carry forward for SBMC that's operational, and we're in contract negotiations with them right now.
And the construction funds have already been, they were like last year or even the year before.
Those are in BGS's budget, and they'll still show as a carryover. They're finalizing the construction budget as well, or the construction contracts as well right now.
And is it like connected to this SBMC?
Mm-hmm. Yes, it's integrated within their main hospital. The original proposal was 12, and it is now down to 11 due to incorporating the availability of a medical bed.
Okay. Okay, thank you, and we can look through the appendices as needed. Is there also an 888 maybe? No.
988.
It's
Yeah.
just 988. There's 888, it's just another toll free.
I think that's a commercial I remember fondly from the 80s or 90s. But 988 is our primary number.
Yeah, suicide and other, because I always just thought it was just a suicide line, but can be other.
Right, if you're having a hard time, you can call. And they're gonna be able to support you, and that's for both mental health and substance use, which is a shift and innovation for our system, so that folks don't have to go through 2 different places.
Great.
That's great.
Well, thank you. Any other last things you want to let us know, or any questions from the committee?
I would love to highlight with 988 that we're one of the first states to incorporate a response decision matrix tool between the 911 dispatchers and 988 dispatchers. So our 911 responders are able to transfer calls appropriately over to 988. And then we are also one of the few states utilizing the BHL software to support centralized dispatch out to those community teams so that they know where each other are and the closest team can respond to someone in that moment.
Well, I would like on slide 37 real quick.
37, you said?
37, yeah, about the youth. Can you remind me what PRTF is?
Sure, yes. And I did not mention that when we went over the pyramid. So the PRTF is, stands for a psychiatric residential treatment facility. And there is one coming online here in Vermont at the Brattleboro Retreat from last legislative session. Currently, youth who need that level of care go out of state. That's correct.
Which is an issue. So this is just giving us the numbers. And what's going to happen at Brattleboro Retreat would be able to take this many?
I believe.
You still have to use that state.
Yeah, I believe that their bed number is also around 12.
Mm-hmm.
So over 12 would still maybe utilize out of state or depending on what a youth needs.
Because we have over 100.
Yeah.
So is it the goal to try to not have them out of state? Or is there?
That is the goal. That's always the goal, to keep them as close to family as possible. Okay. And so Vermont doesn't have a PRTF. And so this is our goal, is to have this level of service for the adolescents.
So that was like Woodside didn't qualify.
No.
Okay. And are they sometimes privately owned? Are these like hospital connected?
The PRTF is a specific designation from CMS, or Centers for Medicaid. And it requires you to, meet several conditions of participation through Joint Commission and CMS regulation. And so they are typically, either attached to a hospital or affiliated with hospital, because there is a higher level of, medical oversight.
Right.
But not a hospital level of care, medical oversight.
Okay,
But they're needed.
Yeah.
yeah, no, because I think I've had some families, constituents that have had their child sent out of state because there was no place for them.
Yeah.
Concern.
Yes.
Okay, thank you for all the good work you do on this stuff.
Appreciate it. Thank you.
Thank you.
Thank you.
Yeah.